a lot of you know me because we've been taking these classes for almost last 2.5 years. So currently I'm working with Dr. Rajesh Sharma as his pediatric intensivist at Jaypee Hospital, Noida. So today the topic is about ICU issues with tetralogy of fallow, atrioventricular septal defect and coarctation of aorta. Now with the nature of talk, it was a bit difficult for me to make it interactive because there was so much to be fitted in one thing. Hence, it's more like a didactic lecture as of now, but I would request that you can definitely make notes, and if you feel that something is not very clear in the post session, we can always have a discussion with me, or you will easily get my email ID and that you can communicate with me and we'll clear it off, right? So now we'll start. Now when we say tetralogy of fallow, just a second. You have plenty of surgical interventions that is done in this entire spectrum, which starts with a modified plaloc dissection, which is done either in the neonatal or in cases with very small pulmonary arteries later on. A single stage repair, which comprises of VSD closure, infundibular resection, pulmonary valvotomy for something like a VSD PS, to a VSD closure, infundibular resection, transaxillary patch with or without a monocusp valve, which is for a classical tetralogy, with or without PA-plasty, again, depending on what is the configuration of the right pulmonary artery and the left pulmonary artery and the confluence. A DORV physiology, where you do a LV aorta routing with a reconstruction of the RVOT. A TOF pulmonary atresia with Rastelli procedure with or without unifocalization. And obviously, a PFO open or closed depends on the RV pressure later, which is an association in most of these situations. Now, whenever a child comes to an intensive care unit, when the handover starts, it always starts with what were the major intraoperative concerns. And it's also important for you to know yet if there was any major significant preoperative cyanotic spill which could have led to any form of a neurological disability. In the post-intra period, whether they've done a step up, especially if there were multiple VSD in a tetralogy or a large difficult to route VSD. What was the RV pressure, whether it was suprasystemic or systemic, whether they have to go back on pump to reconstruct the RVOT, something like that. RVOT gradient, how much of the gradient is left, because that will determine the amount of free PR that's there, especially in a transannular patch. Whether the LV was small. Now, this is something which probably people who have been working in this field would have realized that quite a few situations with tetralogy where a hypertrophied RV with a DORV physiology sometimes results in a very, very small LV. Now, this small LV after VSD closure sometimes starts failing, and hence the concept of putting LA lines even in few tetralogy. Like my surgeon ends up putting up LA lines for all tetralogies, but a few surgeons don't put it for all tetralogies, but only for those with the smaller left ventricle. Besides, those with huge returns on pump, very large returns on pump, which indicates very significant collaterals, which are not very big. Now see, most of the tetralogies which present late and these segments, they always either have a catheterization study or maybe a CT angio before that to see the collaterals, and whether, if suppose the collaterals are very big, sometimes even the collaterals are sort of embolized at the time of the catheterization. But they all have that evaluation. But there are many situations where you have minimal collaterals, very small collaterals, you cannot do anything to correct them, but they turn up as a huge returns on pump and lead to a lot of LV volume overload later. A transthoracic echocardiography, whether it was done or not done at the time of surgery, to see the completion of the surgery and to whether everything was adequately repaired or not. Now, when we come to the ICU, you have the anesthesiologist and the surgeon are giving a handover. Besides all the regulars about CPB, ACC, type of ET tube, type of lines, and all that stuff, there are few things which you should ask preactively as to whether what is the volume responsiveness of the patient. Because we all presume that a tetralogy can be given volume freely, but there are segments in tetralogy with severe diastolic dysfunction. There are segments in tetralogy with a small LV where you cannot give volume that freely, and if you end up doing that, you will actually end up becoming creating a pulmonary edema immediately. So hence it's very important to reassess with consultation with the anesthesiologist who's handing over that if we gave volume, what was the response of the LA and CVP. A PFO absent or present, that will determine two things, whether because that will indicate that the surgeon was not very comfortable leaving a high RV pressure and he's left a decompressing PFO. Okay. Also, from the ICU point of time, while we are very careful for every situation, in these scenarios, it's very important that the concept of de-airing the line before giving any injection becomes imperative. Besides, presence of ET blood. Now, if there is a presence of endotracheal blood, that could be a sign of either a preoperative infective component which has been there, or it can be a site of the beginning of a reperfusion injury. So that information is important. And obviously a pre-op hemoglobin and coagulation profile, because if somebody was deeply polycythemic, you have a patient who shifted to the OT with a HB of 22 and a hematocrit of around 65, and he comes to you with a HB of 10 with a hematocrit of 30, believe me, you will never be hemodynamically stable because he is not accustomed, his body resistance and vasculature is not at all accustomed to a hemoglobin level of 10. They don't have a habit to function at that, and you will have a lot of hemodynamic issues, and then it's important to the pre-op hemoglobin and coagulation profile, especially if the patient is draining. When you see the patient, besides your regular clinical examination, few things which you should always keep rechecking and rechecking again and again in such patients. The rhythm can be sinus, junctional, or sometimes there may be an AV dissociation, especially if there's a VSD with inlet extension. Our right bundle branch block is an invariable association, so you don't really worry about it. You have to see whether the patient is on atrial pacing or AV sequential backup depending on his rhythm. Sometimes a slow junctional may require atrial pacing, AV dissociation may require AV sequential, so on and so forth. A slow sinus sometimes may require atrial pacing, especially if suppose there is an element of very rapid rewarming and the patient is actually not warmed up as much as he should have. Okay. The inotrope strategy really revolves around center. You really cannot force your inotrope strategy on any specific center. Everybody has their own comfort zones. Some people use dopamine, some people use dopamine, a few people use bilrinone plus adrenaline. As long as it works for you, it's fine. But there are 3 or 4 caveats we should remember, that you should not give a high dose of either a dopamine or adrenaline, because that will lead to tachycardia, and tachycardia is something which none of these patients like. Milrinone, at least in our setup, we use only in tetralogies where there's significant diastolic dysfunction or there's a small LV scenario with LV dysfunction. And the milrinone always is given only after adequate volume optimization. Starting milrinone before that will only induce hypotension, and you will end up jacking your supports for no reason. So milrinone has to be chosen very judiciously. If you have a case with significant RVOT gradient, especially the VSD period surgery, always avoid chronotropy. You may not supposed to exceed the dobutamine or dopamine beyond 5 mics in such patients, because a high heart rate will actually lead to a total cessation of the RV outflow and blockage of the RV outflow because of the contractility at high rate, and you will actually precipitate a low output status by giving an agent like dopamine, dobutamine, or adrenaline, which is at a higher level. You observe for the drainage and you monitor your ACTs, your hematocrit, your pre-op PT-BT INR, your platelet count. All these things you will have to keep at the back of your head when suppose the patient is draining. Titrate protamine according to the ACT. FFP can be given as a colloid, and cryoprecipitate is only used to specific issues like specific coagulation factors in a scenario is reported preoperatively. Specific coagulation factor deficiency. You also should ensure that the hematocrit is maintained in tandem with the preoperative polycythemia, as I mentioned earlier. So somebody who was with a HB of 22 before surgery, you don't want to keep a HB of 22 in the immediate post-op, obviously not, but at least try to keep a hemoglobin of 15. And platelets, especially with severe associated polycythemia, there's a lot of thrombocytopenia as well as platelet dysfunction associated, and hence it's important that you, in a patient who's oozing blood, you will always take care of it. I just have to take a phone coming from the hospital. Just excuse me for a minute, please. Hello. Yes, yeah. Nothing. अभी क्लास ले रहा हूँ मैं, वेबकास्ट ले रहा हूँ, मेरे को 1 घंटे बाद चाहिए. Dr Vishal Singh is the ICU like that photos. I'm sorry. Okay. So to continue. So now when you do an echocardiography, And I presume that every intensive care fellow should be present when an echocardiography is done in the ICU, because that is how one learns, A, and also you get to know more about what is happening. Now, what do you see in a tetralogy after repair? You assess the intravascular volume status. What do you see for intravascular volume status? You see your IVC collapsibility. Even on ventilation, spontaneous breathing, obviously it is more profound, where you can really make a strong comment. But sometimes, even on a ventilation, you can make a comment on the IVC collapsibility. Plus, at the same point of time, if it is a severe diastolic dysfunction, the distended IVC will give you a lot of ideas as to how to manage that patient in future. You have to see what is the level of RV filling. If the RV collapsing on itself, that means the patient needs volume. If the RV is over distended, please restrict volume. And RV can be distended even in a tetralogy. You can have a late presenter with very severe dysfunction and he may not like volume. The LV size, we have already talked about the small LA, the small LV and the high LA in the corresponding situation, especially with the TORV physiologies. Biventricular functional assessment, obviously that goes without saying. And any significant residual deficit, like a significant RVOT gradient, of severe PR, a tricuspid regurgitation which is more than what you expect, and any pleural or pericardial collection. Okay. Volume, you must have all learned that volume should be given to a tetralogy, but how much volume to be given? Now, for an open heart surgery, normally you advocate crystalloid to a level of 2 ml per kg per hour. In a tetralogy, maybe you can go to 3 ml per kg per hour, I'm sorry. But if you have to go beyond 3 ml, always titrate your CVPs and LAs adequately. Don't overdo the volume, because that is all going to go into the lungs, especially the crystalloid volume. Balance the crystalloid with colloid. So if you require volume, give crystalloid at 2 to 3 and manage with the colloid at 2 to 3 ml per kg. Probably that will be a better idea than the giving just a plain crystalloid. Besides, if you have to give a colloid, the choice could be between a packed red blood cells, FFP, or 5% albumin. Now, albumin obviously is expensive in a smaller child, but it's always better to use an albumin compared to an FFP, because all sudden you may do a lot of testing on the blood and on the FFPs and everything. But believe me, it's better to use an albumin for a smaller child. I'm talking about a child below 6 months, because invariably the amount of blood and the FFPs that you give to any patient, there is an element of lung injury that invariably happens. There is an element of increased predisposition to sepsis, which happens, and hence it's always better to be treading on the safer side. In the small LV segment, LA pressure should be your guide rather than the CVP primarily, because if the LA pressure is on the higher side, you will have to restrict volume. Otherwise, you'll end up precipitating pulmonary edema. And you should avoid volume boluses in these scenarios. How do you identify that a patient of low tetralogy is going to a low cardiac output state? Well, very simple clinical points. There's peripheral vasoconstriction with a worsening core to peripheral temperature gradient. You'll find that the core temperature is rising and the peripheral temperature is falling. A most important sign of the child proceeding towards LCOs. Increasing potassium, decreasing urine output, worsening metabolic acidosis in spite of giving volumes, increasing serum lactate levels, and a persistent tachycardia with a systolic blood pressure less than 25th percentile. Now, these are the signs that should make you worried. A tachycardic cold patient with borderline blood pressure after tetralogy in spite of volume is not very good news. And here you have to be very cautious about how much volume you give. You have to give volume, but balance it out. You have to give inotropes, and you may have to use pressors. But it's rather than giving a very high dose of a pressor and not giving volume, which will lead to more problems. Give volume and give a low dose pressor. Titrate your inotropy in such a way that the heart rate does not increase. So you have to really choose things properly. You can use something like a dobutamin plus minus adrenaline. You can, depending on the choice, there are institutions which use amilrenone plus minus adrenaline. Some people use only dopamine plus adrenaline. But don't overdo the inotropy and pressor, because the tachycardia is not going to help. And also maintain a balance of volume with the inotropes. That's the message. What are the arrhythmias that you see in these scenarios? Sinus tachycardia very frequently. And if there is a sinus tachycardia, assess volume responsiveness, control the core temperature. You can control the core temperature, especially if it's increasing beyond 36.5 by giving cold saline washes. And if it goes beyond 37, you may have to think of using your antibiotics. because this I'm talking about the rectal temperature, especially if it's going beyond 37.5, 100% you have to use antibiotics. Optimize electrolytes. Make sure that you're giving magnesium in the maintenance dosage, especially if it's a malnourished child. Now, don't wait for a cellular magnesium level to come in. It will take 4 hours. You can always start maintenance magnesium, which is 0.1 ml per kg of a 50% solution, given 12th hourly. And obviously, you can always later on see your magnesium levels and see how the things go. Maintain an adequate sedation in analgesia. You should not have a situation where because of the improper sedation, your patient is tachycardic. And the choice of sedation could be between opioids. Again, very specific concerns out here that is very center-based. Some people like dexmedetomidine, some people like only fentanyl, some people like only morphine, midazolam. Can't really say whatever works for you, use it, but don't overdo it, don't underdo it. You should know where you stand and which balance is good for your patients. Like we normally give fentanyl around 10 micrograms, or I may say so, 1 microgram per kg per hour. Okay. And dexmedetomidine we give up till a dose of 0.4 microgram per kg per hour. And in spite of the sedation and analgesia, if you still have tachycardia, you can think about digoxin and beta blockers, depending on what is your unit policy. Again, some people use digoxin, some people use beta blockers, but areas where the significant RVOT gradient is there, beta blockers are better. Now, junctional electrical tachycardia is the most common tachycardia or arrhythmia in a tetralogy situation. We all know that junctional tachycardia is nothing but junctional tachycardia is an atrioventricular dissociation at a faster rate. Can lead to hemodynamic stability, and if it is with significantly deteriorating hemodynamics, you have to consider amiodarone bolus followed by infusion at 5 milligram per kg, given at least over half an hour. That's the bolus, followed by infusion at 10 microgram per kg per minute. You optimize the electrolytes and volume status, control the core temperature, supplement magnesium, maintain adequate sedation and analgesia, and ensure if the rhythm is getting better, great. Otherwise, if it's deteriorating hemodynamics, do start amiodarone, don't delay it. In those patients with stable hemodynamics, you can always consider beta blockers, especially if the RVO2 gradient is around 40, it always works better. Now, if you have a jet and if you have a fast rate, it is also essential to ensure that you don't overdo the diuresis, because that can precipitate further problems. And you target a potassium around 3.5. Atrial overdrive pacing can be used, especially if the rate was not too high for age. And I hope you do understand what is overdrive pacing. Now, when you come to the progression of the patient, how do you proceed? Now, on the first POD, now for a VSD PS, uncomplicated tetralogy, early extubation is the norm in most of the situations, especially if there's no evidence of excessive drainage, low cardiac output state, arrhythmias, and a 2T echo within the expected realms. The extubation criteria is very much uniform. The patient has to be hemodynamically stable, awake and alert, urine output adequate with desired negative balance, and arterial blood gas status which is satisfactory for the patient's disease and lung condition, adequate gas exchange with satisfactory respiratory effort on pressure support, ventilation, normal lactate, no acidosis, and a documented good ventricular contractility with no residual deficit. Besides, ensure that there are certain situations where this early extubation may not work out. So choose your cases well. Fast tracking and everything is good as long as you know where you are doing it, you are sure about the background of the patient. But in certain situations, fast tracking can lead to disaster, because if you have a patient with practically no blood flow in the lungs with a severe preoperative polycythemia and innervance correction, maybe taking him off is not a very good idea, because you have to give his lungs that much time to adapt to the increased blood flow, and also the element of ventricular dysfunction that may be there. So normally, as people say that the RV dysfunction is better off the ventilator, it is a very agreeable point. But if you have a polycythemia with the lungs not adapted to high blood flow, you can be in a problem. So be cautious. Okay. If there's a huge transfemoral patch, again, the ventricle has to get adapted to the PR. The lungs have to get adapted to the blood flow, so on and so forth. A long segment PA-plasty, again the same scenario. In very unfortunate situations where you have severe cyanosis, but the collaterals are practically not there, this also happens. In conditions where you excessive LA return or pump, suggest multiple small collaterals. So both ways, It requires a little bit of observation, especially in scenarios where you may have to think of delaying the extubation till you are very much convinced that the things are fine till the first POD or the late first POD. And the preoperative severe RV systolic and diastolic dysfunction. I think we would have heard this thing, reperfusion injury related to the perfusion, but reperfusion injury also is observed in the ICU, especially in cases of TETRALOGY, wherein you find that a patient who had very small pulmonary arteries and was not getting enough blood suddenly manifests as blood-stained AT secretions with severe pulmonary hemorrhage. This happens primarily if they extubated a tad bit prematurely. And I think all of us who have worked for more than a decade in this field, we have seen these situations, because we all believe that RV is good after extubation, but if the lungs have not adapted to the blood flow, post taking of the positive pressure, they flood big time, and with flood, they bleed. So this is primarily due to poor adaptability to increased blood flow, occasionally due to multiple small aortopulmonary collaterals, and a small segment is contributed by deranged coagulation profile secondary to severe polycythemia with a deranged intrinsic coagulation mechanism with thrombocytopenia. If suppose you do end up in a case with prolonged ventilation, and when I say prolonged ventilation, it's more than 24 to 48 hours, always ensure the hematocrit is maintained in line with the preoperative hemoglobin to sustain hemodynamics. I've already illustrated it before. Optimize your ionotrophy. If small RV, severe RV dysfunction, Meldon may help in optimizing the patient after you have maintained adequate filling pressures. So Meldon can be used as an add-on either to a dobutamine or adrenaline. And also titrate daily fluid balance based on hemodynamics and thread spacing. A long-standing patient invariably will accumulate fluid in his body, but how much negative you want to keep, whether 10 ml per kg, whether 20 ml per kg, will depend on the hemodynamics, will depend on the level of third spacing, ascites, pleural collection, so on and so forth. Nutrition extremely important, especially when we go into the territory of prolonged ventilation. So hence it's important to start feeds from the first POD. If the patient is still ventilated, you go HG later on, you can always go to oral. If you have a situation of high pressure or inotropy required with prolonged ventilation, then always ensure that you go slow on feeding. Don't overdo the feeding in a patient on high pressure and inotropy doses. If significant GI bleed secondary to deranged coagulation mechanism or thrombocytopenia or stress bleed, use your GI cord saline washes, PPI, and supportive therapy. And in such situations, as well as other situations where you fail to feed the child, you should do a TPN or a PPN depending on your unit protocol. So primary message: maintain stress on nutrition. Always question yourself in the morning rounds, like what are we going to feed the kid? If you're not feeding the kid, how will we maintain his basic parameters and to deal with his resting energy expenditure? So you will have to titrate your maintenance, your energy feeds to a resting energy expenditure of the child, which in the first 4 days, important. Sepsis is a reality in our nation, especially in scenarios like malnutrition, DJOT syndrome, preoperative hospitalization, and the patient getting admitted in a quasi-emergency, or recovering from a community-acquired sepsis, but because of repeated spelling, operative again in a quasi-emergency. These are the situations where a threshold for diagnosing sepsis should be very, very high, and you should be investigating the patient accordingly. I'm so sorry. Okay, now if somebody is having fever beyond 48 hours of CPV, if somebody is having a worsening thrombocytopenia beyond 48 to 72 hours of cardiopulmonary bypass, a hemodynamic instability not attributable to the residual issues of worsening myocardial contractility after a period of stabilization. So a hemodynamic instability irrespective of myocardium. That is what this message is, that if your patient was sick to begin with, got better, and again gets hemodynamically sick, and your echo shows, oh, everything looks fine. Why the patient is having hypertension? Think about it, that there could be a problem. This patient could be going into sepsis, especially if he's having fever, thrombocytopenia, hypoglycemia, leukocytosis or leukopenia, feed intolerance, and elevated sepsis markers. Now, CRP doesn't really work in those situations in the immediate post-op. Ideally, you should do a procalcitonin trending, more specific than an isolated value beyond 48 to 72 hours of CPV. Okay. Now, modification of antimicrobials is strictly guided by the antibiotic policy and the local sensitivity patterns. Though if open chest significant hemodynamic instability or drastic worsening of sepsis stream, consider upgrading to optimal gram-negative cover, especially in our scenario. Gram-positive cover should be given if there is a suggestive history of preoperative community with acquired respiratory sepsis, especially if it's a community-acquired respiratory sepsis just before the patient got operated, and in a situation with leukocytosis with normal platelet counts. So, if you have a worsening thrombocytopenia, deranged coagulation profile, hypoglycemia, gram-negative likely, but if there was a history suggestive of preoperative community-acquired respiratory sepsis, and you had a leukocytosis with normal platelet count because the patient was operated in a scenario of, if I may say so, partial emergency, coming with repeated cyanotics, but the surgeon decided to take a complete repair immediately, and he did not want to wait for the infection to get controlled altogether because he felt we'd end up losing the child. So this situation arises, and you have to take a balanced decision. And in those scenarios, you may have to give gram-positive cover. So choose your antibiotics properly. I won't give a plan. It all depends on every unit policy, but you should monitor what you are giving and why you are giving. If your patient is absolutely fine hemodynamically and your markers are not very bad, not too bad platelet count, and somebody starts a carboplatin straight off, well, it's not very convincing. So always, you can always manage with either a cefoperazone sulbactam or a piperacillin tazobactam based on your unit sensitivity patterns. Now, send the cultures, wait for the reports, things will work out normally, but don't overdo the antibiotics, especially in the first 42 to 72 hours, unless and until you have adequate evidence for that. Third spacing, this is a problem, especially in any prolonged ventilation, especially the patient was with myocardial dysfunction. Okay. Patient is stable. So, if you have excuse me, Rajesh. Hello, can you hear me? Rajesh? Rajesh, can you hear me? Please cut down the background noise. There's a lot of background noise which is coming, so please cut it down. Okay, so I'll continue. If there is third spacing, which is a reality in patients with prolonged ventilation, especially with myocardial dysfunction, because that may be the reason that you're ventilating the child, you have to cut down on crystalloids. You can't overdo the crystalloids to 3 ml, 4 ml per kg. Make sure that you don't exceed overall crystalloid, including the infusions, or to more than 2 ml per kg per hour. You can consider an albumin-induced diuresis, like we use it in our unit, where you know that you cannot give too much volume. Your hematocrit, your patient is third spaced, but you want to get the albumin level up beyond 2.5. You will always give a 20% albumin, which can be given to a tune of 1 to 2 gram per kg per day, depending on your renal profile. Again, optimize the hematocrit. In early infancy, sometimes you may require a peritoneal dialysis to get rid of the peritoneal fluid, but ensure that you don't overdo the dialysis part if your patient's renal profile is normal, A, and also if the patient is draining significantly, ensure that you don't drain it very fast, because that will lead to a major hemodynamic instability and you'll end up in a problem. So drain it with control. So you partially clamp the drainage and let the PD drain gradually, and you can balance your colloids accordingly. Okay. If there is a situation with significant peritoneal drainage, there's no point of giving heavy doses of Lasix and metalazone and all that stuff. Always titrate your colloids accordingly and balance it out. So in such situations, if I may say so, a simplified rule is whatever is draining per hour, in that scenario, based on your hemodynamics, you decide that you supplement a balance of colloid and crystalloid to cover that drainage. For example, if he's draining 20 ml per hour through the PD, you try to give at least 15, but that 15 should be a balance of colloid and crystalloid. Now, don't overdo that. If your patient is draining 20 and going 40, you will never come off the ventilator. So that much sense should be applied. But if he's draining continuously through the peritoneal cavity, and it is like in spite of your controlled drainage, he's around draining 15 ml per hour or 20 ml per hour, give at least 2/3 of that in the balance of colloid and crystalloid will help you better. And the moment the peritoneal drainage reduces, you cut down and improve your diuresis. So this is to be done on a minute-to-minute basis or an hour-to-hour basis, if I may say so. What's happened to this now? Now, coming to the neurological issues that we face, especially in a long-standing tetralogy, it can be either a cerebral thrombosis or a cerebral abscess. And this is primarily a problem in late presenters with severe polycythemia, as it happens in our setup quite a few times. Now, very important that you know that the preoperative evaluation and neurology consult is complete. The patient is on anti-seizure medications, and the antibiotic therapy ideally completed before intervention, especially when a cerebral abscess, unless you have to intervene because of an emergency due to severe myocardial dysfunction with worsening cyanosis with no significant forward flow. These scenarios do happen. We have also treated patients with active cerebral abscess, but who are coming in a dead and dying situation. You have to intervene and do something to get them right. But your antibiotic therapy and everything has to be programmed according to the protocols. And as you know, they will have to give a balance of clindamycin with a gram-negative cover, just to ensure that broad spectrum, especially in an empirical and broad spectrum cover, is done completely. Micronutrient supplementation, especially in these late presenters with neurological problems, is extremely important. So calcium, zinc, B complex group, folic acid, besides many others like selenium, cobalt, in patients prolonged congenital heart disease, untreated, poor nutrition will always help you. Now, after this was regarding the tetralogy, repair and its spectrum, and the problems that you see in a prolonged case and the problems that are there in a regular case. Okay. And now we come to the BT shunts. Now, BT shunts can be very dicey. When done in an older age group, they look simple, but there also you have to keep a strict level of monitoring. But in the neonatal BT shunt is always a challenge. So, always when you get a neonatal BT shunt, make sure that you're taking the intraoperative information about what was the reason for the child to go in the OT for immediate surgery, whether he had a major cyanotic spill or whether it was ductus that closed and he crashed, any major hemodynamic instability either because of the ductus closure or because of sepsis. And you should ask what happened in the OT, whether the child bled significantly or whether he's oozy, because that will help you program your blood product therapy later. Any component of preoperative sepsis which there. Now we all know that neonatal BT shunt is usually not elective. It's always an emergency intervention after pre-op stabilization partially with prostaglandins, inotropes and whatnot, and ventilation obviously. The post-operative situation in any BT shunt and neonatal BT shunt specifically, optimized volume status. Now this optimized volume status is a very broad word. Look at your filling pressures, look at your systolic blood pressures, look at your liver size, the base of the chest, and obviously if you have SS2 and echo machine, always look at the IVC. That will give you an idea as to how much volume you need to give. And it's a closed heart surgery, so you can give up to 3 to 4 ml per kg of steroid to begin with, sometimes even 5. But over a period of time, then you should come down. Once the patient is totally stable, you should come down to the usual 2 to 2.5 to 3 in a closed heart surgery. That is 2 to 3 ml per kg per hour. But targeted SBP beyond 50th centile for age, use balanced inotropy but avoid tachycardia. They usually come out with a combination of dobutamine plus minus NORAD, dobutamine plus minus vaso. That's the normal combination that in our scenario they come out, especially the neonatal patients with sepsis where there's an element of catecholamine resistance. You always use vasopressin. At least in our setups, we always use vasopressin in these scenarios. Avoid hematocrit beyond 40 in a shunt because you don't want the blood to be too thick, simply put. Titrate colloids in the form of 5% albumin and balanced steroids. Avoid FFP because on one hand you'll be giving heparin, at the other hand you're giving FFP. Doesn't make too much sense unless and until you're very unfortunate to have a heparin resistance where you have to give FFP. Heparin infusion is initiated at 10 units per kg per hour in the immediate postoperative period. It's no significant drainage, and obviously sedation and pain relief has to be maintained. Now, in a patient with neonatal BT shunt, whether you like it or not, there will be one episode of desaturation either associated with invasive procedure like AD section or occasionally patient getting wide awake around 4 to 6 hours after surgery. You'll be very fortunate if it doesn't happen. But sometimes, come what may, you may take all precautions, but still it will happen. And that is the reason you should be always very, very observant around this phase of time for the BT shunt's behavior. This is primarily attributed to the increased pulmonary vascular reactivity exacerbated by transient hypoxia, along with autoregulation with reactive vasoconstriction in face of shunt flow. So you had a situation where the patient was not receiving any blood in his lungs. Suddenly he starts receiving blood, and the natural body tendency is to autoregulate, and resulting in reactive vasoconstriction and increased PA pressures, further exacerbating hypoxia because the shunt is decreased. But if you manage it properly, It will be managed. It will never go into a area of shunt blockage. This should be documented. Hence, it's always imperative that whenever the patient comes and within 2 hours you document the shunt flow, start heparin, make your fluids and everything, and target systolic blood pressure. At least above the 50th centile should be maintained. Always auscultate the shunt murmur in the intraclavicular zone or with the bell of a stethoscope at the ET hub. And remember that the diastolic component loss is the first sign of impending shunt blockage. Okay. Then secondly, you have a situation where you have to, now you had a patient who is desaturating. Your cardiologist comes and does an echo and says the shunt flow is not looking as good as it was before, but I don't see any clot, but it's not looking as good as it was before. You have to really pull up your socks, optimize your crystalloid volume for the next 2 to 3 hours to the tune of 10 ml per kg per hour as against the regular 3. Increase heparin infusion to 20 units. Titrate pressures to improve his BP to make sure the blood pressure increases, and increase the FALLOT transiently. Once the patient is stabilized, you can always look at extubation. In the regular BT shunt at late infancy or an older patient, maybe they can get extubated on the same day or the first day. But in the neonatal BT shunt, it's always better to give them time to settle for overnight and then extubate them the next day. And if the patient is essentially stable with no major hemodynamic concerns, he can definitely be extubated. But avoid excessive diuresis. You don't want the patient become too negative. And if no third spacing, avoid diuretics altogether. Start aspirin at 5 mg per kg per day on first POD and stop heparin after 4 hours of dosing. Ensure pain relief. Start feeds in the first POD as is for any other case who's extubated, and titrate tapering of supports gradually from the second POD. Now there are situations where the neonatal shunt just goes ballistic, either because of pre-op sepsis or just the lungs are not ready to sustain the blood flow, and you have significant hemodynamic instability. The patient requires re-exploration for a block BT shunt. Obviously, this patient cannot be extubated soon. Pre-operative significant sepsis component, and third spacing exacerbated by PG1 infusion used pre-operatively, and child shifted with chest open. The concept of shunt overflow now. A shunt overflow manifests usually on the first POD with persistent oxygen saturation more than 85%. The patient has a wide pulse pressure with excessive third spacing, hepatomegaly, and lung crackles, and increased vascularity in the radiological picture with pleural effusion. Sometimes, not always, sometimes. Okay. Now, what do you do in this situation then? Okay, the cardiologist may confirm the shunt is flowing a bit too much. It's already done. The surgeon doesn't want to clip it, and probably you also don't want to get it clipped because you feel that they get too small. So restrict fluids. Don't go to 3 ml per kg. Keep at 2 ml per kg per hour. I'm sorry, it's not day, per hour. 2 ml per kg per hour. Crystalloid. Maintain a controlled diuresis with laxus infusion with intermittent small boluses. Maintain mild hypercapnia. Decrease FALLOT to room air gradually so that you don't have oxygen-induced vasodilatation and more flooding. Ensure an adequate afterload reduction so the systemic perfusion is maintained and the run-through the BT shunt is reduced marginally. So use dobutamine oblique peridone. And occasionally, even in a BT shunt, you may have to do PD, especially if you get significantly third spaced with ascites. Now coming to the spectrum of complete atrioventricular septal defect. Now we all know that complete atrial septal defect can be a balanced, unbalanced, but here we're talking only of balanced, which has undergone a complete repair. Unbalanced becomes a totally different cup of tea because that is about entire single ventricle management, which probably is a separate class we have to take for that. Okay, because single ventricle management goes in a totally different territory. In a biventricular repair patient, when he comes to you, well, it has got intraoperative concerns are primarily whether the surgeon is able to create 2 AV valves with minimal regurgitation or stenosis. The ASD screws properly, the VSD screws properly, and there are 2 balanced ventricles. Okay. In a intraoperative handover, always ask about heart block, whether there was a significant heart block recording AV sequential pacing. In the inlet VSD, it can happen. I'm sorry. Pulmonary artery hypertension is always there in cases with your AV canals, but this is the only scenario which still comes out with PA lines. So you can monitor the PA lines in a sedated situation. They will essentially look normal, but the moment you reduce the sedation, you will see the real picture, and hence always go in a graded way again out here. But it's always essential to monitor pulmonary artery hypertension in cases with Down syndrome and even in older children who are operated for AV canals. Residual AV valve leak, as people who have worked for a long duration in this field know that if you have a major residual AV valve leak, it's a doomed situation. A residual VSD with a PFO creation to decrease RV pressures if any. Now, in the ICU handover, always talk about your rhythm, the requirement of pacing. Talk about what were the hemodynamics inside the operation theatre. How was the LA behaving? How was the CEP? Because the CEP will give an index of the RV pressures and LA will give an index of the LV pressures and LV function. Whether Melatonin is on board, whether a transesophageal or if I may say so, thoracic echocardiography has been done. Thirdly, always remember to ask whether they had to give nitric oxide because the patient was not coming out with the regular vasodilators. And the intraoperative echocardiography assessment before the chest is closed is important to rule out any residual deficit. I hope you would have all seen the situation where if the AV valve leak is profound in a patient with AV canal and it is not repaired, the patient will never come out. So always remember that intraoperative assessment, and if the surgeon is informed about that properly, they will definitely like to correct it a little bit better, and that will help you in the long run. And obviously for the step up, a step up where you see for the VSD, whether it is a residual VSD is there or not. A step up of more than 10% indicates you can have a residual VSD, which is significant. On the zero POD, the goals are usually very simple. You have to, once the drainage stops, titrate volume strictly to 2 ml per kg. Again, I'm mistaken, I've written per day, it's per hour, I'm so sorry. Per hour of crystalloid. Ensure the hemodynamics are stabilized with the balance of inotropy and inodilators. The colloid volume is added on as 5% albumin at 1 to 2 ml per kg if hypovolemia is documented to ensure adequate filling pressures with LA less than 8 ideally with a mean arterial pressure around 45 to 50. So LA has to be strictly monitored while giving volume because this is not a condition which really likes volume. But in certain, where there are significant AV valve regressions and everything, you have to give very balanced volume, balanced inotropy, dilators so that a patient makes it. A 2D echo with color doppler is repeated to assess the ventricular contractility and residual issues and titrate Melatonin and levosidomide based on the unit strategy for LV dysfunction. Again, one has to maintain adequate sedation in analgesia. You don't have to talk about it again and again. It's a given. And fentanyl with SOS muscle relaxants, Dexmed, especially if there's no evidence of slow sinus or AV dissociation, or before any invasive intervention, ensure adequate sedation is given to control the pulmonary vascular reactivity. The signs of ulcers are already documented. Low cardiac output state is also common. In both of them, low cardiac output state can happen, but there you can give more volume, here you cannot give volume, you have to titrate to inotropy, pressure, and inodilators. You should ensure that if there's recurrent desaturation, it is an indication that the patient is likely of severe pH, and pulmonary hemorrhage is further confirmatory. And in that case situation, you may have to use PEEP occasionally of a higher side to control the pulmonary blood pressure and ensure deep sedation. A patient with a drifting heart rate with declining blood pressure with or without desaturation is bad news, and hence never ever leave an AV canal who's sick, because when he starts to decides to go totally ballistic and go crash, you will never know. And they can go anytime. They are one of those segments where we all have seen those once in a while, just absolutely sudden monitor becoming a flattening. So very watchful. Be very watchful. Arrhythmias occasionally seen in preoperative sick infants, CPP-induced vasodilator shock, manifesting as catecholamine-resistant hypotension with a low threshold for vasopressin and systemic steroids. Now, in this situation, if you have a thing where your patient went into vasodilatory shock post-operatively after AV canal, consider giving steroids. Start vasopressin with a low threshold. Don't wait for the situation to get very bad. If you have a vasodilatory shock because of a preoperative sick status, your in vivo body stores of all your transmitters and receptors are depleted, especially related to catecholamines, and you should be giving vasopressin, which will be more beneficial. Otherwise, you'll just extend the misery of the child. Diuresis is usually started once the patient is warmed up on the zero POD, and the ventilator weaning plan is based on degree of third spacing ascites. The overall stability of hemodynamics and gas exchange, and if any episode suggestive of pulmonary vascular reactivity while weaning, episodes of bradycardia and desaturation, sudden decline in PO2 with drifting of sats less than 95%, increasing hepatomegaly with decreasing your output. Extubation is definitely ruled out. So it will always be a gradual process for such patients. And post-extubation 48 hours are equally important. A group of patients, again as I said previously, where PA line is put handsomely and very regularly by the surgeons. At least our surgeon puts PA lines for all the AV canals that we do, even children, especially between the age of beyond 3 months, definitely all the AV canals. And as we just talked about the severe lung pulmonary hypertension, you know that we have to give pulmonary vasodilators. So you are aware about these medications that we are talking about. So we don't go into the respective pharmacologies. They were phosphodiesterase inhibitors like sildenafil, endothelin or milrinone, endothelin receptor antagonists, alpha receptor blockers like phenoxy, endothelin receptor antagonists like your bosentan, and nitric oxide. We don't use nitric oxide. We use it very rarely, because we have got very accustomed to managing our pHs with the help of oral and IV sildenafil with bosentan plus minus your phenoxy. And it involves a judicious usage. You can't really say that what is right, what is wrong. Again, you have to give the balance to a doctor because he also has a head. The dosing directed to sildenafil 1.5 to 2 milligram per kg per day, but when on sildenafil, always monitor your leukocytosis and leukopenia. If they are getting very leukopenic with neutropenic, you may have to stop it. If there's pulmonary hemorrhage, you have to stop it, especially if it is thrombocytopenia. An IV sildenafil is again available for the last 2.5 years, and we can give as a 0.1 milligram per kg loading, followed by infusion of 0.03 milligram per kg per hour. We normally use a 0.1 milligram per kg per day loading. We rarely give in the ICU. We just start with an infusion and manage, and it works if it's required, especially for the PAPH. But it is only when the oral vasodilators are not working or they are not making much of a difference that we start the IV vasodilators, like IV phenoxy, which again given a 0.5 to 1 milligram per kg per day, and bosentan is given as 2 milligram per kg per day. But 70 to 80% of our cases they can get managed with a combination of sildenafil and bosentan. The primary reason, well, I cannot give you a rationale of why you're combining both sildenafil and bosentan. We're just looking at minimizing the dosage and side effects, and also ensuring that if there are any episodes suggestive of pulmonary vascular reactivity while bleeding, episodes of bradycardia and desaturation, sudden decline in PO2 with drifting of sats, hepatomegaly increasing with decreasing urine output, please don't extubate such a patient. You'll be in a disaster. Always plan a weaning based on what is the level of third spacing. If no third spacing, good blood gas exchange, as we have already mentioned in the criteria for extubation, go ahead. But if your patient is swollen, if your gas exchange is not optimal, your platelets are on a declining trend, never extubate an AV canal, you'll suffer. Management of pH, again coming to that, sildenafil 1.5 to 2, IV sildenafil only if the oral vasodilators are not working, IV phenoxy 0.5 to 1 milligram per kg per day. Again, it's an IV vasodilator which can be given if your oral vasodilators are not making much of a change. Sometimes these patients can be very resistant. And in those situations, if you have a facility to use nitric oxide, use nitric oxide at 20 to 40 ppm for 48 to 72 hours with the overlap of oral and IV vasodilators while weaning nitric oxide later. The criteria for extubation, again, as I said earlier, remains the same. Watch for PA pressures with lightened sedation. If it is less than 1/3 to 1/2 systemic, it augurs well for you. Because in a sedated situation, the PA pressures will be good. But it's only when you are coming off sedation to really get the exact picture as to how much of the PA pressure control you've achieved. Because whatever you were titrating just now was based on the echo, the TR gradient, the pulmonary excitation, or the pulmonary diastolic pressure gradient, and that is all. But the real clinical picture of reactivity emerges only when you are finally reducing the sedation, allowing the patient to wake up, allowing him to breathe spontaneously, and assess. But if it is less than 1/3 to 1/2, believe me, you'll be able to slide through. Declining systemic blood pressure with rising PAP while you are weaning the patient with desaturation indicates crisis. Please don't move ahead. Allow the patient some rest and then move ahead again after 48 hours. pH is something which tends to burn out with time. It can burn out in 7 days. It can burn out in 2 months. You can only try whatever you can externally, but If you try to force things on the patient, you will end up repeatedly re-intubating and all sorts of things. Successful extubation is definitely can be achieved if timed well with all the criteria which we have already discussed, all the points and parameters satisfied, besides inadequate respiratory effort and the diaphragm moving normally. So in our unit, as a policy, we check diaphragms for every cardiac below 5 kilos as to whether the diaphragms are moving normally and they are on pressure support ventilation. Nutrition, again, is a very important part because they also have quite a few malnourished children, especially in our scenario with AV canal because of the recurrent pneumonitis and everything in the preoperative phase. With a short duration of ventilation, you usually start on the first POD and build up gradually, and post-extubation revert to oral feeds. But if prolonged ventilation, target 100 kilocalories per kg per day and protein 2 gram per kg per day, gradually rising. So you have to increase. If you don't start this on the first POD, you reach this level by the 5th or 6th POD, especially if hemodynamics and end-organ function are preserved. Subsequently, based on the nutrition status preoperatively, you can increase to a maximum of 150 kilocalories per kg per day with a protein intake of 3 grams per kg per day. What are the reasons for extubation failure? pH crisis. Second is respiratory fatigue due to progressive atelectasis, due to associated laryngotracheobronchomalacia, due to preoperative poor nutrition status, and dilated pulmonary arteries compressing the weak airways. In view of these two things, we normally expect our AVCs on nasal CPAP, especially if they're below 6 months, to bypass this component altogether. Diaphragm palsy, if not checked, you missed out, you can bounce back on you. And if there's significant AV valve leak, if I mentioned it earlier, or a residual VSD in an AV canal, the moment you reduce the ventilation or take off the ventilator, you will have severe pulmonary congestion and you will have to go back. Down syndrome with the atrioventricular septal defect is a common association, and in these patients, important to look at the thyroid profile before surgical intervention and essential to re-evaluate the thyroid profile after 70 to 96 hours. Cognizance of upper airway compromise is imperative, especially after extubation. So ensure that in a Down syndrome patient, you always look at how the patient is positioned, how the patient is being nursed in the ICU, because sometimes the new nurse may actually mess up the neck, and that can lead to problems for you later. So while you are evaluating the thyroid profile and everything for this patient as per the protocol, when you extubate such a patient, please keep a check on the upper airway. And also important to maintain the calcium and magnesium homeostasis, because you know that hypocalcemia invariably will lead to stridor in these situations. Finally, coarctation of aorta. Now this is something which is not exactly a very basic ICU scenario that you really get worried about in an older child. But in a neonatal coarctation, obviously you have problems. So it may present as an acute emergency with severe LV dysfunction with a right to left shunt to maintain systemic circulation through ductus. It requires stabilization with IV-PGV infusion along with inotropy and vasopressors. And in the coarctation, avoid anodilators, like you avoid something like a bilrodone, dobutamine as the primary pressor or inotrope, because you will end up having problems because you already have an obstructive LV dysfunction due to obstructive gradient ahead. Correct the metabolic acidosis as it exacerbates myocardial dysfunction. Ensure that the ICU handover mentioned specifically regards any radiofemoral gradient. As you would have seen, they all come out with radial lines and femoral lines for the arteries. Any intraoperative rhythm issue, hemodynamic, or any respiratory issues that is of concern because which can influence your postoperative management. And confirm baseline neurological assessment by looking at the pupils fontanelle, and once he gets awake by looking at all the movement of forelimbs and the gaze. The postoperative management of a neonatal coarctation centered around optimizing LV function with the balance of inodilators and vasopressors, dobutamine oblique bilrodone plus adrenaline. This is after repair, by the way. Okay. Avoid crystalloid exceeding 2 to 3 ml per kg per day in view of the LV dysfunction. Titrate the volume based on preoperative renal spacing and renal status and third spacing. Use colloids, PRBC, FFP albumin based on hematocrit and the coagulation profile. If the 2D echo study with doppler to assess LV dysfunction reveals that the function is good, there's no residual coarctation gradient, you can always plan a weaning extubation on the first POD or sometimes on the second POD, depending on how well the ventricle is moving and how the child is maintaining his end organ function, whether he's having any third spacing. So the same criteria of extubation about being awake and alert with good urine output, everything comes here as well. But if there's no significant thirst spacing with good diuretic response and the LV function is improved significantly, it will not be normal of 55% or something, but if it's improving significantly from what it was preoperatively, you can definitely consider extubation on nasal CPAP, because it's always better to give a non-invasive CPAP to a patient who has LV dysfunction. Adequate gas exchange with no metabolic acidosis and normal lactate levels will further enhance your confidence to do that. And if he did not have any improvement in multi-organ dysfunction, like his renal profile and LFT is still deranged, probably you have to give some time. But if things are improving, you can definitely, like in just 2 weeks back, we had a situation where the child came really sick, but then ultimately post-surgery within 24 hours, his parameters started normalizing after surgery. So we had to resuscitate him, send him to the OT, and post 24 hours it started normalizing, but we still gave him one more day because the LV function was still around 25%. And only when the LV function came to around 35 to 40, we got him off. Always, as I just said, extubate nasal CPAP if mild LV dysfunction is persistent. Keep NPO for the first 48 hours. Again, this is related to the post-coarcectomy syndrome, which you have read even in your basic pediatric textbooks, that a gut which was not perfused will suddenly gets perfusion, and there's autoregulatory ischemia, and hence you guard it for the first 48 hours. Start with clear feeds, enhance to half strength very gradually, and later to full strength very gradually with a check on abdominal girth, vowel sounds, and NG aspirate, and ensure antipsychotic prophylaxis. In a post-infancy or a late presenter cohort, preoperative hypertension is usually associated, we are all aware of it, with associated LV dysfunction, can have rhythm issues, especially ventricular arrhythmias. Multiple collaterals can be there, which is there to bypass the obstruction. And pertinent postoperative issues include control of hypertension with choice of beta blockers and calcium channel blockers only given beyond 8 years of age. Post repair, if there's no gradient across the radial and femoral, can consider ACE inhibitors, especially if there's no residual gradient across the between the aorta and the descending aorta, ascending and the descending aorta, because normally this is around the juxtaductal coag that we talk about. Now, if due to collaterals in an older patient, you do not have major GI issues, but it's always better to tread on the safer side. Keep a watch on the abdomen even in these situations. Even though we all know that the collaterals are there, he may not clearly getting some new blood flow. He was already having blood flow out there due to the collaterals because it's a late presenter. But still observe for the GI issues as a protocol. And maintain the blood pressure, try to titrate the blood pressure so that use a balance of beta blockers, plus minus calcium channel blockers, plus minus ACE inhibitors, only if there's no residual gradient. But if there's a gradient, manage with the beta blocker with the calcium channel blocker. Finally, this is entire slides that I have made out here. Probably I never refer a text for this thing because been in this field for almost 17 years and it's a continuous learning process. And till date, you'll find, and once you progress in your careers, you'll find that every day is a new learning. The only thing that takes you through is continuously educating yourself about what you are seeing on a day-to-day basis and never giving up in an ICU. Thank you. If there's any questions, they are welcome. So there's a question from Dr. Sneha Jain, and she has asked if the patient with PA crisis, should we start both sildenafil and bosentan together? No, we should start one of them based on a unit policy. And if you see how it works, if it is not working, probably add another one. That makes sense. Starting both of them together, you really do not know what's working, what's not. So you have to see the responsiveness and then decide. We start with the bosentan in situations where the LFT is normal. And we give bosentan, build it up gradually to a 2 milligram per kg per day. And subsequently, if it's still not there working, then probably we have to look at something like the sildenafil. Okay. Anybody else? Any questions? Hello. Hello.
Hello.
Yeah, Rajesh.
Nagesh, doctor.
So just wanted to know if there's any questions from anyone. We can continue. Otherwise, we can delink.
Yeah, 1 minute, doctor.
Yeah.